Hi, this is Dr. Ash. I work as a consultant emergency medicine in UK, and normally I do a lot of courses along with my A&E consultant job. I teach MRCEM, PLAB, do emergency medicine courses in Pakistan and Dubai. But because of this corona pandemic, it's really not possible for me to do the courses on site, practically, physically, and I really miss the teaching bit of my life. For last 3 months, we are very busy with corona pandemic in London. This is the park which is very close to my hospital where I normally come and sit. This is the place where I come and reflect on my day. I just sit here and I don't talk to anyone. But now I'm thinking when I come here, why is it a good idea to share something valuable with you all? So, being an emergency medicine consultant is not a very easy job. It's really, really tough. You have to take so many decisions in a very short time. On average, we take around 50 to 55 times. As an A&E consultant, you will be interrupted on floor by juniors, nurses, healthcare assistants. You sign so many ECGs, and a number of times there are so many things which has to be consultant sign off. The most important presentation, which is the chest pain, which is every SHO or registrar, whenever they see the chest pain, they will come to discuss with you. And being an A&E consultant, it's very important that you should be able to extract important information from their history and be able to make a safe plan for the patient. Because number of times patients with the chest pain, they die, and people have to face litigations and they have to go to court, especially in the United Kingdom. So I thought I should select a topic of chest pain, how I deal chest pain in UK, what is my way, and what is general practice here, so that we can help others in making this decision, especially in Pakistan and third world country, where there is no as such regulations or pathways. Every hospital follows their own protocols. So I thought it's important to share my thoughts about the chest pain, how I deal with that. So chest pain is always very worrying, for not only for the family but for the clinician as well. And of course, the first thing comes to your mind of anyone has a chest pain, you will think about heart attack, isn't it? Or in medical term, we call it myocardial infarction. Now, if you ask me how I scrutinize, if an SHO comes to me with a chest pain and says that I want to discuss a chest pain with you, what I do, I think of 4 or 5 major disastrous conditions in my mind first, and if they are fine, then I'm not too worried about the patient. So, of course, the first thing is MI, heart attack. So, how do I rule out heart attack, and how can we safely make this patient safely discharged home or sent to the appropriate specialty? So, with the heart attack, of course, you have to ask very good history. Normally, the chest pain of the heart attack is very vague. It will never be localized. It doesn't usually change with the posture. So, if the patient says that someone is sitting on my chest, I feel very heavy chest, I feel very tight chest, and the pain goes to the neck or jaw or arm, this is usually a cardiac sounding chest pain. So then, if I think this is a cardiac sounding chest pain, then I ask for the risk factor. What are the risk factors to this patient? What's his age? Is he a smoker, non-smoker? What's his family history? Any heart attacks, hypertension, diabetes, all this, cholesterol. So these 5-6 things which will help me risk stratification. Now, examination has got a very limited role in chest pain, especially with the heart attack. You don't see anything, you don't find anything. Of course, if the patient is sweating or the patient is vomiting, that means that his sympathetic nervous system is stimulated and he is showing symptoms, systemic symptoms. Then, once the history and high risk factors, if they're suggestive of heart attack, Of course, we do the ECG. All clinicians in the United Kingdom are they have a very good knowledge of ECG. So normally, most of the time, most of the heart attacks are normally picked up. If the ECG is suggestive of heart attack clear cut, like if there is an ST elevation MI, then we refer them to cardiologists for angiography and angioplasty. But the problem arises when the ECG is normal. Then again, if the history is suggestive, we do the troponins, cardiac markers on the blood test. This way you can actually find out who has got heart attack. Patient may have FTMI heart attack or NFTMI. I think this is really very common. Most of the doctors are very good at picking up heart attack, but the purpose of my video is not teaching you heart attack, is to what not to miss, and that's the important part. The second most important diagnosis which we don't want to miss is pulmonary embolism. Of course, this used to be really very challenging in the past when we didn't have enough investigations and scoring systems. So now, fortunately, we have a lot of investigations which we can predict which patient has got pulmonary embolism or not. Pulmonary embolism, for those who are non-medical doctors, non-medical people, is a clot in the lung, and it's a clot in the lung which can actually kill the patient. It's a deadly disease, and most of the time it is missed. So how I ruled out the clot? So again, with the clot history, always ask what type of the pain is this. This pain is usually different from the heart attack pain. The pain is usually localized, pleuritic. It's worse on movement, breathing, and there will be, if the pain is suggestive of clot, then it's important to ask for the risk factors. We ask risk factor for any chest pain anyway. For risk factor for clot, who gets the clot? It's important to ask them. If the patient has got recent surgery done on the leg, limb, is he recently immobilized, does he had a long flights, has he got a leg swelling, or patient is pregnant, or contraceptive pills, or family history of clots. So at least these 6-7 questions I asked them, whether there was any history of clot or things, or hormonal use. So these patients are at more risk of getting clots. Now, if the history is suggestive, again the examination will be very limited in this case. Yes, patient may be hypoxic, oxygen saturations may be low, and patient may have a high fast heart rate, which is called tachycardia. So then we do the ECG again. In ECG for pulmonary embolism, for clot, there is nothing usually you see other than just sinus tachycardia, which is a fast heart rate. But sometimes if the clot is really very big, you can actually see the features of pulmonary embolism on ECG. So of course we do the ECG. Now, so this is the way I really systematically rule out the chest pain, heart attacks and clots. If the patient is low risk and has got no risk factors as such, then there's another blood test which can be done, which is called the dimers, widely used everywhere, and we can actually use that test to find if there's a clot. If D dimers are negative, then there's a very high chance that there wasn't any clot. So with a simple test, you can actually detect life-threatening conditions. How can we forget about pneumothorax? Pneumothorax is like an air trapped around the lung, and the lung gets collapsed. It's really important to think about spontaneous pneumothorax in a young, fit and healthy person who is tall, thin, and these are the patients who can get spontaneous pneumothorax. Other population is people with lung problems, COPDs. So if someone comes with a sudden onset of shortness of breath, pleuritic sounding chest pain, I normally ask them what bothers you more, is it the pain or breathlessness? If they say it's breathlessness is my main concern, then I start thinking about clot and pneumothorax. Then it's very easy to pick up. You just do the chest X-ray, and you can actually find pneumothorax and it can be treated, it can be cured with a very minimal intervention. I know about few patients in Pakistan where few of the family members, they contacted me and they told about the patient who was a young, fit and healthy. All of a sudden he had a chest pain, then he died. So I asked them, did you do the chest x-ray? Or some number of times people don't even get the chest x-rays and diagnosis. So it's very important you just do a simple, basic history, bit of examination, do the ECG and get a chest x-ray done. Now the important one, the most important, which we don't want to miss, is the aortic dissection. Dissection is a nightmare for doctors, especially in A&E, because just for those who are not medical doctors, I would like to explain what is dissection. It's a big blood vessel which comes from the heart and supplies the whole body, called aorta, and that is called the tearing of the aorta. So when the aorta gets tear, like literally like someone is cutting the aorta, it's a big blood vessel and patient can bleed to death. This is another nightmare for us. Heart attacks easily picked up nowadays with the ECG, troponins, and a high degree of suspicion. Everyone knows about it. Pulmonary embolism, again, you can pick up with the history and with the D-dimers. You can do the chest X-ray. If the chest X-ray is negative, then it's going more in favor of pulmonary, embolism. Then the aortic dissection. Yes, this is the nightmare, as I was saying earlier. How do I diagnose dissection? It's really important and challenging when an SHO comes to me and say, oh, I've got a patient, 79 years old, with the chest pain. Now it's really hard for us to make a decision. Could it be dissection? So there is a high degree of suspicion when the clinician starts to think of dissection. What I normally do is I ask the history about the dissection. The pain of dissection is really very severe, is characteristically, and the pain goes directly into the back between your shoulder blades, and it will be like a tearing chest pain, like someone is actually cutting your aorta. So ask your patient, is he having a chest pain which is going to his back, radiating into between the shoulder blades? And usually these patients are very sick. They may be sweating, diaphoretic. So start thinking about it. But most of the time you don't get this proper history from the patient. Then what are the other methods? I try to screen. I try to save myself by asking SHO what is the blood pressure of the patient. So when the blood pressure is quite high, like say for example, systolic blood pressure is 200, 180. And diastolic is 100 and 110 or something like that. This worries me a lot. So anyone with a chest pain with a very high blood pressure, start thinking about dissection. Could it be dissection? And then ask your SHO or junior doctor to check the blood pressure in both the arms. So there will be a difference of blood pressure in one arm and the difference of blood pressure in the other arm. So if the difference is more than 20, that's really very significant. So it's very simple thing which you can actually do. Now, other thing about the dissection is ask about the chest pain plus symptoms. It's really important. Most of the time, doctors don't ask chest pain plus symptoms. They really don't dig deep into it. What is the chest pain plus symptom? Any pain, chest pain, any symptom which is chest pain plus above the neck or below the diaphragm. So if someone is coming to you with the chest pain and he's also complaining of dizziness, he's also complaining of stroke-like features, he's also complaining of visual problems, he's also complaining of at least a sore throat or a hoarseness of voice, or if he's complaining of any vision problems, then start thinking this is a chest pain plus symptoms above the neck. You'll be surprised that I have picked up a patient with the chest pain, dissection, with the drooping of the eyelid. I have picked up the patient with the hoarseness of the voice because the mediastinum was spreading and the patient said this is not my right voice. So this is another way. Chest pain plus symptom is any symptom below the diaphragm. The chest pain and abdominal pain. You can't have both of them. And if you have them, then think about it, that this could be dissection. Or any tingling, numbness, leg weakness, whatever. So history of dissection is very highly suspicious degree. History of the chest pain going to the back, with the chest pain plus symptom, high risk features, high blood pressure, difference in both arms. Just do that very quickly. And now, this is based on the history and examination. But what about, is it still safe to send this patient home? I don't think so. There's still more you need to do, which is get the ECG now. When you get the ECG, remember, if you have ischemic changes in the inferior leads, with the very high suspicion of chest pain going to the back, high blood pressure, and the heart attack changes are in inferior lead, think about it. Could it be dissection? Because in dissection, the right coronary artery gets dissect first, and then patient can present as an MI as well, inferior wall MI. So the teaching is not yet over. There's a lot more to teach. I wish I can teach you more on chest pain. It can go hour and hour, but I'm trying to summarize as much as I can. Yeah, where were we? We were talking about dissection. So think about, if the ECG shows inferior lead changes, then think about with high blood pressure, high degree of suspicion, think could it be dissection before you give antiplatelets and heparin, because that can actually kill the patient. Now, this was ECG. Again, chest X-ray will be really very helpful. I always do chest X-rays with the chest pain now, because it can give you a lot of information. If it's normal, then you think of pulmonary embolism. Sometimes it can pick up small lesions in the X-rays of the lung, like small cancers and stuff, which can present as a pleuritic chest pain. So do a chest X-ray. It's a basic requirement. And with the dissection, the mediastinum will be widened. There will be other subtle features of left-sided pleural effusion. These can be the aortic dissection features on the X-ray. Now, the most important part of this talk is the numbers, scoring system. It's really very important. As an A&E consultant, A&E physician, you must use the scoring system to protect yourself. For example, you're thinking of heart attack. Write TIMI score, write Grace score. Normally we are now very good at picking up heart attacks, but the things which are missed, pulmonary embolism, it's really important that if the patient is a high risk of pulmonary embolism, we just do the CTPA, CT pulmonary angiogram, and we pick that up. But what if the patient is low risk? It's really important to protect yourself. The most popular scoring system for that is now pulmonary embolism rule out criteria, which is called PERC score. I use that. And if the PERC score is 0, then actually you don't have to do the D-dimers. So even if someone has sent the D-dimers, you can actually disregard them. So there are 8 parameters for the PERC score. You can Google it. It's really very nice. It's been validated and it's been used by many big hospitals of the London. So whenever you see a patient, if it's not a heart attack, if you think it's a pulmonary embolism, if it's not a pulmonary embolism, try to do a PERC scoring. And last but not the least, recently they introduced a new scoring system for aortic dissection, which is a nightmare for us, which is called ADDRS, which is called aortic dissection detection risk stratification risk scoring system, which is really very good score. And I'm really very glad that this scoring system is now available for us, because before that I really didn't know who should we proceed for CT aortogram or not, who should we just do ECG and send them home. But now after this ADDRS scoring system, it's really helpful for me, and I recommend all of you to please use it. How to use it? So it says basically three points. One is 3 criteria. One is if the patient has a high risk features, like he's got previous heart surgeries, or aortic manipulation, Marfan syndrome, or connective tissue disease, and then he presents with the chest pain, which is classical of aortic dissection, there is a separate, so one is the risk factors, previously known to have any other problems like Marfan's or aortic manipulation. Second, ask about the classical presentation, which is the chest pain, sudden onset, worst, going to the back, and then tearing like pain, difference, and then examinations. If there's a difference of pulses in both the arm, if there's a difference of pulse pressure in both the arm, if there's a difference of, if there's a radiofemoral delay. So if any of those are present, if someone scores more than 1 point, you have to go for CT aortogram. And if someone does not score more than 1 point, you can actually do the D dimers like you did for the clotting PE. And if the D dimers are negative, then there's 85% chance, D dimers are positive in 85% of the patient with dissection. So the life has been really now easy for me to deal the chest pain in the United Kingdom. Is that I rule out heart attack by just doing simple ECG and blood drop cardiac troponins. If they are negative, then we are quite happy to send patient home or deal as an outpatient. For pulmonary embolism, simple, we do the chest X-ray, ECG, and D dimers. If the D dimers are positive, we do the CT pulmonary angiogram, and if D dimers are negative, we just send them home. So, and the last, the dissection one is pneumothorax. You do the chest X-ray, you can find the pneumothorax easily. And the fourth one is the dissection of the aorta, where you do the make sure that you took a very good history, chest pain symptoms, chest pain plus symptoms, iris features, and then if use the ADDRS score, use the PERC score for pulmonary embolism. If ADDRS score is less than 1, you do the D dimers, and then if D dimers are negative, you can actually safely send patient home. No further imaging is required. So if I summarize the chest pain, it's really very easy now for me to deal the chest pain in A&E. Simply take a full history, risk factors, type of the pain, do the X-ray, do the ECG, and nowadays we do the TROPS and D dimers, which actually and apply the scoring system. So do 4 things: a good history, risk stratification, ask the question for the risk factors. 3, do the ECG and chest X-ray. 4, do the TROPS and D dimers, and actually you will be pretty safe to send patient home. I hope this session was useful. I think I already spent 20 minutes. I have to go home now. Thank you very much. If you like my video, just do let me know so I will share more. And if you want me to discuss some more important EM stuff, like any medical condition or any presentation which you are not sure, feel free to comment in my on the post. I will definitely bring some important stuff. Thank you very much, Dr. Ash.